Let's go over the warm-up review. First question, where are nicotinic acetylcholine receptors found in the body? So they're found at the neuromuscular junction, and then don't forget the autonomic ganglion as well. That's the first step in getting both the sympathetic and the parasympathetic nervous system, those nicotinic receptors in the autonomic ganglia. And also the adrenal medulla, which you can think of as just an overdeveloped, specialized sympathetic ganglion. Next, which drug category has each of the following endings? So operidol are neuroleptics, phenyl are the methylxanthines like theophylline, pterol are beta-2 agonists, triptyline are the tricyclic antidepressants, and zosyn are alpha-1 blockers. And the last question, what are the systolic heart murmurs? So you have mitral regurgitation, tricuspid regurgitation, aortic stenosis, pulmonic stenosis, mitral valve prolapse, VSD and possibly an ASD, hypertrophic cardiomyopathy, and then PDA produces a continuous machine-like murmur, so it's both systolic and diastolic. Now we're ready for the lecture.
Welcome to our Step 1 video on reproductive anatomy. Let's start with the male reproductive anatomy. We can review these structures by going through the pathway that sperm takes during emissions and ejaculation. Sperm are produced in the testes, which are found in the scrotum. Specifically, the sperm are produced in the seminiferous tubules of the testes. The testes are also where testosterone is produced. After the sperm are formed, they pass through the epididymis, which is the structure sitting on top of the testes. Next, the sperm travel through the ductus deferens, which is also called the vas deferens. This is what gets cut during a vasectomy. The ductus deferens passes through the inguinal canal as a part of the spermatic cord. It then enters the pelvis. It joins with the duct of the seminal vesicle to form the ejaculatory duct. Secretions from the seminal vesicle empty into the ejaculatory duct and mix with the sperm to make semen. The ejaculatory duct ends in this prostatic urethra, the portion of the urethra that's surrounded by the prostate gland. The prostate gland also contributes to the fluid in the semen. And then finally, the sperm will move through the urethra to exit the penis out of the urethral meatus. I'll just mention the bulbourethral glands, or Cowper's glands, sit here to produce mucus that enters the urethra for lubrication. So again, the pathway for sperm. It starts in the seminiferous tubules of the testes, then goes through the epididymis. Next, they travel through the ductus deferens, or vas deferens, into the ejaculatory duct, which empties into the prostatic urethra, and then the sperm travel through and out the urethra in the penis. Next are the layers of the penis. So, for the layers of the penis, starting from the outside and working our way in, you have the outer dermis, and then the superficial fascia, or Dartos fascia. This is continuous with Colles fascia of the perineum and the Scarpa fascia of the abdominal wall. Next is the deep fascia, or Buck's fascia, which is a continuation of the deep perineal fascia. And it's important to note that Buck's fascia separates the corpus spongiosum from the corpus cavernosa. You'll see that it forms a roughly looking figure 8 with these structures. And then there are 3 cylindrical masses of erectile tissue that are encased and separated by the tunica albuginea. The 2 corpora cavernosa, which are dorsolateral, and the corpus spongiosum ventrally. And then, deep within the corpus spongiosum is the urethra. Let's move on to female reproductive anatomy. So, you have the vagina and the cervix, and then moving up is the corpus, or body, of the uterus, the larger, rounder part. Bilaterally, you have ovaries, where oogenesis takes place, and where the female sex hormones estrogen and progesterone are produced. And then, in close approximation, are the fallopian tubes. After ovulation, the fimbriae will sweep the released egg into the fallopian tube, and then the egg will move down the tube and into the uterus. If fertilization occurs, it usually happens in the fallopian tube. There are a bunch of ligaments that help support these structures. Let's go through these. The cardinal ligament connects the cervix to the pelvic sidewall, so you can remember C for cervix and C for cardinal ligaments. This contains the uterine vessels. The infundibulopelvic ligament is also called the suspensory ligament of the ovary. It connects the ovary to the pelvic sidewall, and it contains the ovarian vessels. Don't confuse that with the ovarian ligament. The ovarian ligament connects the ovary to the uterus. It's derived from the gubernaculum, as is the round ligament of the uterus. The gubernaculum in males attaches to the testes and helps the testes to descend through the inguinal canal and into the scrotum. In females, the round ligament of the uterus comes off the side walls of the uterus, travels through the inguinal canal, and ends up in the labia majora. And then finally, we have the broad ligament. This is a double fold of peritoneum that covers the uterus, the fallopian tubes, and the ovaries, and it connects them to the walls of the pelvis. It also contains the ovarian ligament, the round ligament, and the infundibulopelvic ligament. So you can think of the broad ligament as being a large, broad ligament that basically covers everything. So again, the cardinal ligaments connect the cervix to the pelvic walls and contain the uterine vessels. The infundibulopelvic ligament, or suspensory ligaments of the ovary, connects the ovary to the pelvic wall and contains the ovarian vessels. The ovarian ligament connects the ovaries to the uterus. The round ligament of the uterus goes from the uterus through the inguinal canal to the labia majorum. And the broad ligament covers everything that connects the uterus, fallopian tubes, and ovaries to the pelvic wall. Let's talk a little bit about innervation of the pelvis. If you can remember only one nerve, remember the pudendal nerve. The pudendal nerve comes off of the sacral plexus, specifically S2, S3, and S4. The pudendal nerve supplies sensation to the perineum and the genitals, including the penis and the clitoris. It also supplies motor to the perineal muscles. This includes the muscles at the base of the penis that aid with erection, and the external anal sphincter, and the external urethral sphincter. The pudendal nerve can sometimes be damaged during surgery or childbirth, or sometimes you'll see damage to the pudendal nerve in professional cyclists. So what kinds of problems would you expect? Well, you can have genital numbness and pain, fecal incontinence, and urinary incontinence. It can also lead to erectile dysfunction in males. One way we can take advantage of the pudendal nerve is a pudendal nerve block. Remember that the pudendal nerve provides sensation to the perineum, so you can block that, and sometimes we do that during childbirth for anesthesia. You basically feel for the ischial spine, and then you use that landmark to inject a local anesthetic into the pudendal nerve. The pelvic region is also innervated by the autonomic nervous system, and this plays a role in the male sexual response, which we'll talk about next. So, sympathetic input and parasympathetic input both contribute to the inferior hypogastric plexus, which is also called the pelvic plexus. And then from there, you have a bunch of subplexuses that go on to innervate their target organs. One of these is the prostatic plexus, and this gives rise to the cavernous nerves. The cavernous nerves carry the parasympathetic fibers to the penis and are responsible for erection. And as you can see here, the cavernous nerves sit basically upon the top of the prostate gland. And this becomes important when you're performing a prostatectomy for prostate cancer. The cavernous nerves can get injured during that surgery, and that can result in erectile dysfunction. So again, injury to the cavernous nerves during prostate surgery can result in erectile dysfunction, because these nerves carry parasympathetic fibers. So now we go through the male sexual response. This is definitely high yield. And what we're talking about here is erection, emissions, and ejaculation. So let's go through each of these. I'm sure you all know what an erection is. Erection is mediated by the parasympathetic nervous system, and specifically, remember that cavernous nerves. How this works is the parasympathetic nerves release nitric oxide, which is a vasodilator. And the vascular smooth muscle cells of the penis, this nitric oxide activates guanylyl cyclase, which generates cyclic GMP. And then, through a couple of different steps, this cyclic GMP causes a decrease in calcium levels, and this leads to smooth muscle relaxation and vasodilation. So then, blood flow in the penis increases, and the corpora cavernosa fills up with blood, and the penis becomes erect. As a side note, this is where the drugs that treat erectile dysfunction work. Cyclic GMP is hydrolyzed by the enzyme phosphodiesterase 5. The PDE5 inhibitors, like sildenafil and tadalafil, inhibit the breakdown of cyclic GMP, so they facilitate vasodilation and erection. So erection is mediated by parasympathetic autonomic nervous system, but there's also a little contribution from the somatic nerve, the pudendal nerve. Remember, the pudendal nerve innervates the muscles at the base of the penis. This causes them to contract, and this helps to maintain that erection. And then you have emissions and ejaculation. Emission is when the sperm moves into the urethra and mixes with secretions from the seminal vesicles and the prostate gland to form semen. And then ejaculation is when the semen is actually expelled from the penis. Both emissions and ejaculations are mediated mainly by sympathetic nervous system. You get peristaltic contractions of the ductus deferens in the glands, and this will help move sperm and secretion into the urethra, which, remember, this is emission. And then the contraction will force the semen out of the meatus, and that's ejaculation. The pudendal nerve also helps here. Contraction of those muscles at the base of the penis will help with this expulsion. So the pudendal nerve does help a little, but what's important to know is the autonomic control. So remember, erection is mediated by the parasympathetic nervous system, and emissions and ejaculation are controlled by the sympathetic nervous system. The classic mnemonic for this is point and shoot. So point is the erection, and that starts with P, like parasympathetic, and shoot is the emission and ejaculation, and that starts with S, like sympathetic. Next, let's talk about the arteries of the pelvis. I don't expect you guys to memorize much of this anatomy right now. With any anatomy for step 1, you probably need to spend extra time with a video or an anatomy book. There's really no quick, easy way to memorize anatomy. But let's get going. First, we'll tackle the female pelvis. From the common iliac artery, the first branch to the left on this image is the external iliac artery. And the other branch off the common iliac artery here, this is the internal iliac artery. And from there, we have many branches, like the iliolumbar, the superior gluteal, and the lateral sacral arteries, for starters. Then, further down, we'll see the umbilical, and off of that, the superior vesical artery. Also, off the internal iliac, we have the obturator, the uterine, and the inferior vesicle, the vaginal, the middle rectal, and the inferior gluteal. Finally, the internal pudendal arteries. At the very bottom, we see the vaginal branch of the uterine artery. Next, let's go over the male pelvis. Again, we start at the top of the common iliac artery. The external iliac is off to the left of the image, and then we see the internal iliac with its many branches. Similar to the female pelvis, there is the iliolumbar, the superior gluteal, and the lateral sacral arteries at the top. From here, it gets a little bit different. Off the umbilical artery, we have the artery of the ductus deferens and the superior vesical artery. Next is a similar appearing obturator artery. And then there are the inferior vesicle and the middle rectal arteries. The inferior gluteal artery is similar, and then the internal pudendal artery will give rise to the inferior rectal artery and also the dorsal penile artery. All right, let's switch gears and talk about venous drainage of the gonads, so the testes and the ovaries. On each side, the ovary and the testes drain to the papiform venous plexus and into their respective gonadal vein. So the right ovary and the right testes drain into the right gonadal vein, and that goes directly into the inferior vena cava. But the left ovary and the left testes drain into the left gonadal vein, but that goes to the left renal vein, and then that goes to the inferior vena cava. So there's an extra step on the left. The left gonadal vein is longer, and because it has to make that extra 90-degree turn, where it can sometimes get compressed, there's an increased risk for pressure in the left gonadal vein, and that's why some varicocele are common on the left side. A varicocele is basically an enlargement in the papiniform plexus because of poor venous return. This is often described as feeling like a bag of worms in the scrotum. It gets worse with the valsalva, but it improves when kneeling flat. Lymphatic vein drainage is also important because this tells you where cancers or infections are likely to spread to first. So the ovaries and the testes, these drain into the para-aortic lymph nodes. The upper 2/3 of the vagina, the uterus, including the cervix, and the prostate, they drain to the external and internal iliac lymph nodes. The internal iliac nodes are also known as the hypogastric nodes, and they include a cluster known as the obturator nodes. The distal third of the vagina, as well as the vulva and the scrotum, these are your more superficial structures, so they drain to your superficial inguinal nodes. I want to finish by talking about two things that are sort of related to anatomy in this area: groin hernias and urinary incontinence. There are 3 types of groin hernias: indirect inguinal, direct inguinal, and femoral. Inguinal hernias are more common and they tend to occur in males. Indirect inguinal hernias are the most common type. Most of these are congenital due to failure of the process vaginalis to close. Basically, the processus vaginalis is an outpouching of the peritoneum. It descends into the scrotum and it covers the testes to become the tunica vaginalis. The rest of it is supposed to obliterate, but if it doesn't, it leaves a communication from the peritoneal cavity into the scrotum. And this communication can fill with fluid, becoming a hydrocele, or it can fill with abdominal contents, and this would be an indirect inguinal hernia. Indirect inguinal hernias protrude through a deep inguinal ring lateral to the inferior epigastric vessels, and then they pass through the inguinal canal and exit the superficial inguinal ring to enter the scrotum. Direct inguinal hernias result as a weakening of the abdominal wall, what's known as a Hasselbeck's triangle. This weakening can be due to things like increased abdominal pressure from constipation or chronic cough or heavy lifting. So direct hernias are generally acquired rather than congenital. Direct inguinal hernias go through the abdominal wall and Hasselbeck's triangle, medial to the inferior epigastric vessels. They exit out of the superficial inguinal ring. So what structures form Hasselbeck's triangle? It's formed by the inguinal ligament, the inferior epigastric vessels, and the lateral border of the rectus abdominis muscles. The third type of groin hernia is a femoral hernia. Remember, going from lateral to medial, you have the femoral nerve, artery, vein, and then the lymphatics in the femoral canal. That's navel, N-A-V-L. Well, femoral hernias protrude through the femoral ring into the femoral canal. Femoral hernias make up less than 10% of groin hernias, but when they do occur, they're more likely to be in a woman, and they're also more likely to cause complications. What complications do we worry about with hernias? Well, mostly we worry about incarceration and strangulation. Incarceration is where the contents from that hernia, usually bowel, get trapped and you can't reduce it. So an irreducible hernia, that's incarceration. When this happens, venous and lymphatic blood flow can get obstructed, so you can get edema, and eventually the arterial blood supply can be compromised. You can get ischemia, necrosis of the bowel, and that is strangulation. So a strangulated hernia is when you have necrosis of the herniated contents. Let's review hernias one last time. An indirect inguinal hernia enters the deep inguinal ring lateral to the inferior epigastric vessels and travels through the inguinal canal and then exits the superficial inguinal ring. Now, direct inguinal hernias go through Hasselbeck's triangle, medial to the inferior epigastric vessel, and then out the superficial inguinal ring. And then femoral hernias, they go through the femoral ring into the femoral canal. And remember that femoral hernias are more common in women. Okay, so now let's move on to urinary incontinence. The three main types of urinary incontinence are stress, urge, and overflow. Stress incontinence is the most common type, and it occurs due to weakening of the pelvic floor, usually after childbirth, so women who have given a vaginal childbirth. So these patients will leak urine when the abdominal pressure is increased, such as with coughing or sneezing. As far as treatments, you would recommend lifestyle modifications first, such as timed voiding, pelvic muscle exercises. The most famous pelvic floor exercises are the Kegel exercises. If those aren't effective, you can try a pessary, which is a device that sits in the vagina and helps to add support. And then surgery is an option for stress incontinence. Urge incontinence is due to overactivity of the detrusor muscle. So these patients will feel a sudden urge to go, and then they have to go right then and there. And a lot of times they won't make it to the bathroom. Again, you want to try lifestyle modifications first, but there are medications that can help, specifically antimuscarinics like oxybutynin and darafenicin. The last one is overflow incontinence. This occurs when someone is unable to void normally because of bladder obstruction or neuropathy. Since they can't void normally, the bladder gets overly distended, and then patients have continuous leakage or dribbling of urine. The treatment for this is to treat the underlying cause. Intermittent catheterization is possible if you can't find the underlying cause. That's the end of this lecture. Let's do the end of session quiz. Let's go through the answers. A professional cyclist develops decreased sensation in the genitalia and the perineal pain and numbness. Which nerve is most likely injured? That's the pudendal nerve. A 67-year-old man with prostate cancer develops erectile dysfunction after undergoing a radical prostatectomy. What nerves were most likely injured? That would be the cavernous nerves. Remember, they carry parasympathetic input, and that parasympathetic nervous system controls erection. Next question. Describe the autonomic control of erection, emissions, and ejaculation. So again, erection is mediated by parasympathetic nervous system, and emissions and ejaculation are mediated by the sympathetic nervous system. What do the following ligaments located in the fallopian tubes do? First, we have the cardinal ligament. This ligament connects the cervix to the pelvic sidewall. It also contains the uterine vessels. Remember, C for cervix and C for cardinal ligament. Infundibulopelvic ligament. This ligament connects the ovary to the pelvic sidewall, and it contains the ovarian vessels. Round ligament. The round ligament comes off the side of the uterus, travels through the inguinal canal, and then ends in the labia majorum. The broad ligament. The broad ligament is a double fold of peritoneum that covers the uterus, the fallopian tubes, and the ovaries. Remember, we said it connects these ligaments to the walls of the pelvis. The broad ligament also contains the ovarian, round, and infundibulopelvic ligaments. So remember, the broad ligament is a large ligament that pretty much covers everything. And what structures make up Hasselbeck's triangle? So it'd be the inferior epigastric vessels, the lateral border of the rectus abdominis, and the inguinal ligament. Where are the pudendal nerves located? What is its function? And what is the landmark used when injecting local anesthetic into the pudendal nerve? The pudendal nerve comes off the sacral plexus, specifically at S2, S3, and S4. Remember, we said the function of the pudendal nerve is to supply sensation to the perineum and the genitals, including the penis and the clitoris. It also supplies motor function for the perineal muscles. The landmark used to inject a local anesthetic into the pudendal nerve is the ischial spine. Last question. Which type of urinary incontinence matches each of the following descriptions? Treated with antimuscarinics, like oxybutynin. That's urge incontinence. Occurs with coughing and sneezing. That would be stress incontinence. And presents as continuous leakage of urine. That's overflow incontinence. Let's go through the rapid fire facts. The main artery of the pelvis, that's the internal iliac artery. The main nerve of the pelvis, that's the pudendal nerve. And a bag of worms in the scrotum, that's the varicocele due to dilation of the pampiniform plexus. Okay, that's it for this video. We'll see you next time.